In the past, when I was in the pediatric training, they used to tell us this is a supplementary, there's supplementary sphincter, and that sphincter is got constricted for whatever reason, and that will prevent blood going to the lung, right to the shunt, and patient will be cyanosis. But the pathologists and morphologists, they studied this and they said there is no sphincter. It's a muscle core, but there is no sphincter. It is a fixed obstruction. And they started to, it is not understood why it happened. Then, the theory started to form that it is multifactorial, and as I mentioned earlier, it is an acute imbalance between systemic and pulmonary pulmonary blood flow. So whenever the systemic side got lower, patient will start to have this phenomenon. Or the pressure on the right side start to increase, the patient will start to have this phenomenon. It is imbalanced. It is like a pressure gradient between left and right. So many factors involved in this, but if we understand this, we will be able to treat this at any stage. It almost always starts with a prolonged crying. That prolonged crying is not the usual baby cry. It is crying because of a reason. Either he's very hungry, in pain, infected, or during defecation, even heavy defecation, if he has constipation and he's struggling with defecation, he might have this. So that prolonged crying will kickstart multiple things. First of all, the pulmonary vascular resistance will drop. Will increase, sorry. So as we always think of right side increased, left side decreased. So crying will increase the pulmonary vascular resistance, and this will increase the right side pressure. If the patient has chest infection will increase the right side pressure. Will lead to some pulmonary tension. Crying will lead to reduced systemic vascular resistance. Now we have the right side increased and left side decreased. This is even worse. Some medication we give by mistake. Patient comes with chest infection. Some habits in the ER, they give Lasix. So you drop the intravascular volume, you drop the systemic blood pressure. Fever. Fever is known to reduce the systemic vascular resistance. So you have multiple factorial. Anything can reduce the left side, can kickstart the problem. Anything increase the right side can kickstart the problem. Dehydration. Dehydration will reduce the RV in the systolic volume. So the venous return to the right ventricle will be decreased. With that, the amount of blood going to the lung will be decreased. So this is the right side. This is as if it is the left side decreasing. So the fever will increase the respiratory rate, will increase the heart rate. Increasing heart rate will reduce the RV volume as well. Less RV volume, less blood going to the lung. So multiple factors as you see here, and you can intervene at this point of time. If the patient has any problem, we educate the family. Whenever a patient has a problem, medical problem, seek medical advice immediately. Don't stay at home and say he will improve. If there's a chest infection, it has to be treated aggressively and immediately. No medication that could affect the systemic vascular resistance. He should be well hydrated. If he has infection, has to be treated. Fever has to be subsided.
That means you need to restrict the IV fluid for this patient. No restriction of IV fluid.
Even give more. And instruct the family to feed him very well, regularly, 2-3 hours. So with that, reduce systemic vascular resistance, increase pulmonary vascular resistance, increase heart rate, increase respiratory rate, with the respiratory rate, the oxygen consumption increases, right? The demand is increasing, and the patient has less oxygen even. So that increase in demand will lead to hypoxia at the end. Increased heart rate will reduce the RV filling, will reduce the pulmonary blood flow, reducing pulmonary blood flow, more desaturation, hypoxia as well. More higher RV pressure, lower LV pressure, more right to left shunt. More right to left shunt will lead to more hypoxia. And that hypoxia will lead to reduced mixed venous saturation, metabolic acidosis, tissue ischemia. Tissue ischemia will lead to more even severe pain and severe crying. And that crying will lead, to start a vicious cycle. It has to be broken down. ischemia, pain, crying, then it's a vicious cycle. But you see, you can figure it out, you can trigger management, you can break the cycle in many occasions, even before the patient comes to the emergency room with deep desaturation. So the management depends on the understanding first. Second, depends on the prevention at home by educating the family what they should do at home. First, they should know that this patient might have this spell. Second, they should prevent the prolonged crying. If he's in pain, they have to figure out why. They should seek medical advice. They should keep the patient fully hydrated. We teach them about the neck, knee, chest position. This might, by itself, can break the cycle. After that, the patient will come to the emergency room. So, in the emergency room, we divide the management to like 4 phases. Phase 1, it is the general measures. We put them in the chest position. We calm the area. We don't put him in the most busy area where he will be irritated and noticing everything. The noise is very high. Everybody is coming, going. The door is opening, closing. We should put him in a calm area, maybe low light, in the lap of the mother, the knee chest position, and provide him with some oxygen. This might kill the spell by itself. This is the general measurement. Before, you don't jump immediately to set an IV line. No, the IV line, we have a patient who admitted in cardiac unit in our hospital because of this. The patient came with the spell, treated in the arm, shifted to the wall, and the wall, nurses going, entering, talking, laughing, whatever, and they jumped to put an IV line by a junior nurse. Crying, another nurse came, then the patient got the spell, arrested, and got to survive, alhamdulillah. So this is a serious and important. The step 2, now we jump to the medical management. So now general management, no medication, nothing, only calming down the patient. This general medical management is a stepwise process. We start with the early step, then if did not work, move further, did not work, we'll move further. But if the patient will not wait, we don't have to start like it's not a book here. The patient is not a book. We might jump and start with the most advanced treatment depends on the patient's condition. So first of all, we give him an oxygen. Via, this is very important, the most convenient method for the patient. We don't force like nasal pump, for example. And we don't like put face mask and tighten it and the patient will be more irritable. We have to kill the irritability of the patient. If he accepts the nasal pump without problem, okay. If not, we give mask. If he does not allow it, we don't force to put it around the head. Put it just near his face. It has to be convenient for the patient. Morphine is a very good medicine, can be given intramuscular, intravenous, if there's an IV line. If no IV line, we give it intramuscular to kill the pain and kill that vicious cycle which gets stopped by the pain. And the patient, when he comes to ER, he might have some tissue ischemia. That pain is not just because he's not comfortable. No, there is something increasing that severe pain and causing that phonetic crying. So we have to kill that pain to help the patient calm down. After that, alternative to morphine, if it's not available, ketamine, but morphine is the choice number 1. Intranasal midazolam is an option as well. It's easy, we can dilute it to 1 to 10 and give it in both nostrils. But it's not as effective as the morphine. Now, if this phase, see, until now we don't have IV line. We don't jump to the IV line. We might kill the patient by IV line. If these measures did not work, and the patient continue to have this phenomenon, we go to the next step. Now it's more advanced step. Establish an IV line by the most expert person in the unit. who's the best, who's number one, please put IV line for this patient. We don't try with junior nurses or regular nurses, no. Who's the best of the best, you should put the line for that patient in the first trial. And once we have a line, we push a large amount of vascular expansion, colloidal crystalline fluid, with 20 cc per kilogram. And this is usually enough to kill with the morphine to kill the spell. If he did not respond, we go to the more aggressive with the IV beta blocker, and we correct the acidosis if there's an acidosis. As you mentioned, acidosis will lead to ischemia as well, and will reduce further the systemic vascular resistance. Finally, in this stage, so the beta blocker to control the heart rate, and that will allow more RV filling, more blood going to the lungs. Tachycardia will reduce the RV filling, reduce the pulmonary blood flow. If it did not work, we go with the systemic vascular vasoconstrictors. The most common is the phenylephrine or norepinephrine. At that time, we should request the fact RBCs, because most of them they need more oxygen carrier capacity to overcome this problem. If these measures did not work, then the last is the same patient for general anesthesia, intubation, and that will potentially kill the patient. And in some cases, we have at least one case where we took the patient from ICU to OR for palliative surgery. In those patients, if you have a patient who is sick, ischemic, in a deep spell, where all the measures fail, it is better not to go on by corrective surgery, not to go with the pump surgery. It's better to do the palliative, secure the pulmonary blood flow, then later on you plan the surgery. So it's like a stepwise management, but it requires good understanding of the palliative surgery to know which medicine is working well. For example, we don't jump to the IV line, we don't give like system vasoconstrictor from the test. No, it can't be like a simple procedures can end the story.
Can you just go back again, Dr. Abdeslam? I would like actually to highlight here, which team are dealing with the patient based on the steps. So I presume the ER will deal with step 1. And then
Anybody can do this.
Yeah, exactly. And then general pediatric and ICU, where actually here the ICU will be called?
This stage and this stage, the time.
I'm talking about cash here.
Yeah. The time is like around 10 minutes.
Yeah.
We should focus on like treating the patient. If he did not respond to this stage, we should alert the ICU team or cardiology team.
Notify them.
The ICU is like maybe who will handle this patient at the end if he requires further advanced steps.
Thank you, Dr. Abdeslam. Just to add for your question, Doctor, if child comes for some predisposing factors, like has a bad sepsis, like has a dehydration,
fever,
diarrhea, anything like this, you want to involve early. If patient is having typical TET spell by definition, honestly, they do very well. By what Dr. Abdeslam, mashallah, wallah, very good.
Released.
You saw the paragraph diagram on the corner, right corner, pain.
It's a pain.
It's the pain.
Control the pain.
Infundibular spasm because of sympathetic overflow. That's all is happening. So if, as I said, for PICU, I'd like to get involved as soon as if you see there is something else, not simple TET spell.
Yeah,
If it's a simple TET spell, just kill the pain. Relax the child, give oxygen, they will do fine.
Yes. It will be killed at this step, like 99% of them at this step. If it did not, and you had to set an IV line, then you should alert the ICU.
But I presume once you reach to using the ketamine, midas, fentanyl, this is PICU. Because this actually you are going to deep sedation.
Then we need the patient needs it. There is something else going on.
Yeah.
He's not responding to conservative.
You might give them the morphine and send them on after that.
Yeah.
That morphine will do the magic.
Most of the ER physicians do that.
Yeah.
Once he settled down, You feed him, give him fluid, and rehydrate him, and you'll see him playing.
Yeah, but actually here in Cash, we admit him for observation if he improves as well, because, they are living remotely.
For
70
recurrent.
kilometer from here,
They need to be referred.
Just a question, if the patient has cyanotic spells and receive for the treatment, and this is the first, cyanotic spells, as I read before that, when you have it, so you should start the propranolol before sending the patient
If
home.
the surgery will not be done soon, yeah, you start.
What is the indication for
If you are not in a
cyanotic
cardiac center, now you will refer the patient to Riyadh, for example, right? I will start with them.
Yes.
Because until
Reflex.
the parent accepted, received in the clinic, seen in the clinic,
Mhm.
this is a long time.
Yes.
Then I will start.
Yeah, can I say, the patient when he go discharge from Riyadh, usually have a brief medical report?
Yes.
Yeah.
No, it's just summary.
That's it, usually, yeah.
Yes.
Because the problem sometimes the patient, they have very complex and they don't have any information, but we usually do that for cardiology.
Some patients, they leave before even the paper is prepared, Even the medication, they leave it until next day. They will just want to go from the hospital. This is the reason. But, everybody has to get all the medication, follow-ups, and the report.
Usually, tell you that you can just make it in the mobile even after labor. And make a copy and keep in your mobile
hospital
because
application,
here cannot
somebody
take
is there,
that.
right? Khalid,
Hmm?
the hospital application, it's just somebody is there.
Yes,
I think it is there.
yes, but I don't know, was this change in the,
I think it is there.
Now, Dr. Salam, because it's a newly opened hospital, it's a new team in the ER, so they don't, so that's why you have to be.
For those cases, that collect that from language. We have that. This is from our book, academics from our book. You can get those tables and put it in the ER manual. Anyhow, unfortunately, most cases are sent to
Thank you.
at home.
Thank you. Appreciate it.
Especially if we educate the family how to manage and how to handle and how to prevent. Most of cases in the emergency room, they not require advanced treatment, and the initial measure are sufficient. The step 1 and step 2. If the patient,
Poster coverage.
after the spell is treated, what is the steps now? As you mentioned, you have to refer the patient for operative surgery, consider beta blocker, and we consider iron supplement if his hemoglobin is not sufficient. So these are the 3 steps post recovery. You want to go over some quiz or we?